My name is Tulsi. This is Elise Nelson. Sorry. And we, as Emma mentioned, had the fortunate opportunity to work in Nepal this past summer for our fieldwork research. And we worked with the Bhutanese refugee population. And we'll go into detail about the Bhutanese refugee population and the field that we focus on, which is mental health. And while we focused on mental health, we both addressed different aspects of mental health or two different factors. And mine focused on the caste system, so the caste hierarchy, and Elise, really I'm not an expert at this. Elise focused on the role of expectations of resettlement. So just to jump straight into it, just giving an overview of mental health, the World Health Organization endorses that there can be no health without mental health. And this slogan has been in the forefront of campaigning and raising awareness of mental health issues globally as well as locally here in the United States. And we can see that globally about 14% of the worldwide disability can be attributed to mental health concerns. So this can be neurological, substance use disorders. Between 12 to 48% of individuals have experienced a mental disorder, and this is a very wide range, and possibly due to the fact that there's poor surveillance regarding mental illness. There's a high stigma associated with mental disorders, so many individuals may not be forthcoming with their disorder. But additionally, in many regions globally, we find that there's a scarcity of facilities and resources available to individuals who may be suffering from a mental illness. So those factors can contribute to why this is such a large range, but very high range in itself. Additionally, when we look at the global burden of disease regarding mental illness, majority of it, or 75% of it, can be found in low to lower middle income countries. And one of those countries that we worked in was Nepal. And Nepal has a their disability of mental illness is about 11%. And when we look at the facilities available in Nepal, there are only 18 outpatient mental health facilities available to the entire population. However, none of those are specifically focused to children or adolescents. So that again is a problem itself. And if we project mental disorders into the future, by 2030 it is expected that mental health or mental disorders will be one of the top 3 issues concerning the global disability attributed to a disorder or disease. So again, it is a growing concern for the future. When we look at mental illness in the context of refugees, we find that they themselves face a host of issues because they're completely dependent on organizations or agencies to provide any needs to be met. As of 2009, it's estimated that there are 42 million refugees globally, and about 50%, about half of them, have suffered or will suffer a mental illness at least once in their lifetime. If we look at what factors can contribute to this, there are numerous stressors at play. So human rights violations, additionally social exclusion, social inequalities, and so forth, can contribute to disorders such as PTSD or MDD, as some of the mental illnesses that they can face. And additionally, talking about health and health facilities, as I touched upon, if we look at refugees, or if we even look in the general population, we find that many individuals do not have access or do not receive the appropriate care that they should when they are facing a mental illness. This is especially true for refugees, where not only are they dependent on a host of organizations, but oftentimes in a refugee situation, many organizations do not have the personnel or the staff or the facilities to even provide basic health needs, let alone mental health services. So just looking specifically at the context of Bhutanese refugees, something that has become a growing concern at a very alarming rate, and very recently, a study by the International Organization for Migration, they investigated claims that there's a usually high rate of suicides, not only among refugees in the Bhutanese camps in Nepal, but also once they resettled here in the United States. And so if we look, there are a number of refugees committing suicides in U.S. that is greater compared to the camps, but also it's triple the rate compared to the U.S. population. So in the United States, about 11 out of 100,000 individuals commit suicide or attempt suicide, whereas the refugees that are resettled to the United States, that rate is 3 times as high, about 27. So that is a very alarming rate. Something that they also interestingly found was that those who are committing suicide once they are resettled, they generally are from the younger pool. So they're younger age, and they are generally individuals who either grew up in the camps or were born in the camps. So something interesting to think about, and also requires further research, especially since they are relocating here in the United States. And then something that Elise will touch upon briefly is that the Bhutanese refugees have a very interesting, complex history behind them. Not only have they resettled to the United States, but they originally came from Bhutan, resettled to Nepal, and then after about 20 plus years, they're resettling to the United States. So as you can imagine, there are a lot of different factors at play and complexities that exist upon the resettlement from Bhutan to Nepal to the United States. So additionally, our focus was on mental health, but we'd also like to address the fact that there are a lot of other health concerns within the population. We also see that malnutrition, anemia, and TB are very prevalent within this population, especially TB, as with any refugee population where you have individuals living in close quarters. TB is very prevalent within this population. What we discovered as a group was that in Nepal, in the camps, those who are diagnosed with multi-drug resistant TB, they are actually isolated for 2 years in this place called Magic Mountain. I'm not sure if that's the appropriate term, but they're actually isolated there. And as you can imagine, not only are you a refugee who has left your home country, which was Bhutan, but you are now isolated from your family. You do not have your own freedom. You have someone dictating the way you live. So that can also add to the complexity of the mental illness framework. So I know many of you guys might be asking, or at least a lot of people have asked me, why did I focus on working with a population that is probably thousands of miles away, and maybe you have never heard of them? So why did you focus on this population? So first off, the United States, and as well as Durham, is as much a part of the global community as any other country, city, or state is. And what a public health concern that may affect an individual miles away can have serious implications locally as well, locally here in Durham. And that's the case because, as I mentioned, many refugees are resettling to the United States, and many of them are resettling here in Durham, North Carolina, so within our communities. And so I'd like to do a little exercise, like a minute exercise. So take a moment and think about the first time when you traveled to another country, whether it was by yourself, with a family member, with a friend, and you went to this foreign country and you didn't really know the language, you didn't really know the way of life, you couldn't just walk into a grocery store and find a jar of peanut butter or something. You didn't really know the way of living there. That's the context, that's the kind of frame of that's a frame of thinking whenever refugees are relocated to another country such as the United States. They're placed in a situation where they're not too familiar with the way of life. They might not know the language, they might know a couple of phrases, but they're not really familiar with the language or how to access a system such as currency or the metro system or transportation. So imagine that, but not only are they living here, but they have to learn how to adapt to this different ways, different systems. And so this brings me to the point of why should we care about it in Durham? Because again, we have refugees relocating to Durham and with their families. And so some of those concerns that come along with relocation are mental health issues and different factors that may play a role with that. So going off of that, Elise and I developed our research projects, again, focused on mental health, but 2 different factors that can play a role in mental health. I focus on the caste system, which I'll go into a little bit more later. But the primary aims of my overall thesis was to understand how different health behavioral patterns are rooted to the caste system. So in a better way to understand how you can address those health patterns. Also examining how psychosocial issues differ between castes. And again, I'll explain how there are different caste levels within the hierarchy. And then finally, exploring the relationship between where one perceives themselves in the caste system and how that may affect their mental well-being. And that's primarily what I'm going to talk about during the presentation today. And ultimately, my goal, as well as Elise, when we were talking about this, was we wanted to address a factor or several factors that can hopefully be addressed before they actually resettle, before the Bhutanese refugees resettle, in an effort to help prevent any mental health concerns that they already have or can grow out of the resettlement process. Now I'm going to pass it over to Elise, who will go into her aims and background.
So here are the aims of my thesis. They look kind of complicated and aren't showing up super duper well. So I'll just try to sum them up for you. So the first one talks about understanding the psychosocial kind of context in which mental health exists in this population. So think about looking at the social and cultural ways in which the refugees understand, experience, and kind of respond to mental illness. And then, or I kind of like to think of it as the mental health landscape, if that kind of helps you picture it a little bit better. So that's what the first aim is. And through that lens, we're going to look at one of the themes that emerged in our research, which was a huge expectation, a lot of expectations about what resettled life is like. And we want to particularly understand the way that these resettlements might put them at risk for poor mental health outcomes once they're in the U.S. Okay. Okay. And the third thing, like Tulsi said, we just want to inform some of the current resettlement strategies, and also just kind of increase the general knowledge base about the Bhutanese here as we start to incorporate them into our communities and become more responsible for their health and mental health, of course. So really briefly, I'm going to give you some background on who they are and why this particular group of Bhutanese are now refugees. So the reason we labeled this slide this way is because the Bhutanese refugee story is quite unique, and in a lot of ways, they became refugees by unbecoming citizens. There's a great book that Michael Hutt wrote, and this is the title of his book, Unbecoming Citizens. And so basically there's this subpopulation called the Loshampas. Oops, is that how you pronounce it? Loshampas? So they're this subpopulation of Bhutanese who were living in southern Nepal. They were kind of, or Bhutan, they were kind of geographically isolated from the rest of the country. They were very agricultural. They also had some very distinct kind of character traits that made them a little bit different from the rest of the Bhutanese. And the Bhutan government, which is a monarchy, didn't really think about them or bother with them much for a long time. But in the mid-1900s, they started enacting these citizenship reforms. And the overall goal was basically to homogenize or create a more homogenized Bhutan. And so at first they tried to incorporate this group more into their culture by kind of giving them, like setting up a lot of rules that they kind of had to conform to, but then eventually it turned into kind of restricting who qualified as citizens until most of them lost their qualification for being a citizen. So they were no longer citizens in their country. Their citizenship was kind of revoked and they were forced to leave, often very violently. And if not violently, from the fear of violence. So they left Bhutan and they came across this little sliver of India and landed right here in southeast Nepal. And after enough of them came, there were, I think close to 100,000 at one point, probably more actually. And so the UNHCR, the United Nations High Commission for Refugees, came and started setting up refugee camps here. I don't think they even imagined at the time that they would still be there 20 years later, but they are. And so they set up 7 camps. You can see the little triangles here are the 7 camps. Now I think there are only 3 or 4, depending on whether Sunshine is closed yet. I'm looking at you for answers, whatever. You don't know. Okay, so they're basically consolidating the camps as they're closing them. So they're bringing them all into these kind of 3 camps in the middle here. And then eventually they're going to close them all down. So in the camps, they live in these little rows of bamboo huts in very close quarters, very communally. They are illegal to work in Nepal, so they're very idle. Some of them do work illegally in the nearby towns, and some of them have small businesses in the camps. For the most part, none of them work. So they rely entirely on outside aid for all of their provisions, like Tulsi mentioned earlier. So the World Food Program provides their food. Caritas provides their education. AMDA, the Association of Medical Doctors of Asia, provides their health care. And yeah, UNHCR runs and manages the case. So now that you kind of know who they are and why they're there, we're going to get into our study. So we used a lot of different methods. They were all very interesting. We learned a lot about different ways you can collect data and information and stories from people. But the main one we used was the life story interview, so that's what we're going to focus on today. And the life story interview is a tool similar to like an in-depth interview. But the difference is it takes the power out of the hands of the interviewer and shifts it into the hands of the interviewee. So even though we had a pretty rigid interview in the sense that, you know, we had a lot of questions and kind of a lot of different categories we wanted to touch on, the interviewee really kind of dictated how we were going to flow through that, how we were going to get to each topic. And then once we landed on a topic, we had questions we wanted to get through. But that way they could kind of create their story and tell it as they saw it. And it created a really comfortable environment for them to tell us their story, and also gave them the correct impression that we really did want to hear their story, and we wanted to hear it from their perspective, how they wanted to tell it. So they were very comprehensive. You can imagine someone coming in and basically saying, so can you tell me about your whole life? And that's basically what we did. And we talked about everything from fears, anxieties, worries, past, present, future, friends, community, favorite season, favorite movies. It was all over the place. So they were really comprehensive, and so of course they took a really long time. 2 to 4 hours is kind of average, but Karen and I did some interviews that took 6, 7 hours, and we had to do them over several days. These are some of the additional methods we used. We don't have time to get into them, but you can ask us about them if you're interested later. So now we're going to jump into results. I'm going to turn it back over to you.
All right. So as I mentioned, I focused my research on understanding how the caste system, which is a social traditional factor within the Bhutanese community, how that may play a role in the mental health of this population. And so I wanted to, before I actually jump into my results, I wanted to provide a brief overview of the caste system in Nepal, primarily because I didn't have much of an understanding of it before I even went into this research project, and I'm not sure if anyone really has a good understanding of it. Not to downplay anyone's knowledge about it, but just so everyone's on the same page, the caste system in Nepal is primarily comes out of the civil code that was written in 1854. It's called the Muluk-Yain. And based off of this system, we see that caste discrimination can come off of it. And so the caste hierarchy is a set of rules or a kind of a framework where individuals are socially excluded or isolated based off of a certain factor within that community or society. Within Nepal, it's based on a hereditary system. So an individual is born into a caste system. And generally, it's difficult to move in and out of that caste system unless it's through marriage. But generally, an individual is born into that caste system. So it's very difficult to disrupt the system since it is hereditary. And also, it's kind of reinforced by the society. So through social isolation, through the way that people live, even through the construction of a house, it's reinforcing the society that people know what caste they belong to. And in an interesting article that I was reading, oftentimes we as Western individuals, we judge it in the sense that this isn't right or it's a moral issue. However, in a society where it's a hereditary process, where it's existed since the 1800s or late 1800s, it's a way of life. It's something that is just ordinary in that system or in that society. So we oftentimes see people who address or who talk about their way of life or their position in society based on the caste system. So the caste system in Nepal itself is broken down into a wide variety of divisions, and then even further divisions and divisions. And so to keep it simple for the purposes of our research and my research, I divided it up into 3 primary groups. So the highest group were the Brahmins or the Kshatris. And again, as I said, it was hereditary, so last name plays a big role. And so oftentimes those who were a Brahmin caste and Kshatri class, they had a last name that was attributed to something similar to being a king or a ruler or a governor. And then someone in the middle was part of the Janajati class. And then someone of the lowest caste within the system were the Dalits and untouchables. And so generally, again, last name plays a role. Those individuals, their last name oftentimes served as an indicator of they belonged to a job or an occupation that indicated they were service deliverers or cleaners, something along those lines. And so we find that when we did our research, we conducted our interviews and we asked individuals what caste they belonged to, or they helped indicate, or if they did not tell us. For the purposes of my research, I went off of their last name. We found that 10 belonged to the highest caste, 12 in the middle, and 3 in the lowest caste. And so based off of that, I decided to focus, again, primarily on the relationship between where someone perceives themselves in the caste system and how that may affect their mental health presently or in the past, possibly in the future as well. And so I used a scale, or our entire group used a scale where we asked an individual, how does caste affect your mental health based on a scale of 1 to 5. 1 represented where caste does not affect your mental health at all, and 5 was at the other extreme where caste affects your health very much so. And so to orient yourself, if you look on this side right here on this column, these were out of 4 different questions that we asked or gained where caste does not affect another individual's health. So this was where we were asking the interviewee, how do they perceive caste to affect someone else's? Not your own, but someone else. And then again, it can affect another individual negatively. And then this was for the self. So this was asking the individual, how do you think caste affects your mental health? So does it affect you personally? 1 or 2, it never does. And then 3, 4, or 5 on that scale again, it does affect you either currently or in the past. And so based off of this, when I was going through the analysis, I used code words based off of, or again, looking at the scale, but also based off of code words of related to mental health. So whether it was like tension or anxiety, which were the prevalent words used during our interviews. And so looking at the number of responses, we see that there's pretty much an even amount of responses in each category. However, the most interesting thing that I found through this was that we see a clustering. So those who were answering that caste does not affect another individual's health were primarily of higher caste. So again, the Brahmins or the Kshatris grouped together, and then the Janajatis, which are in the middle. And again, remember that within a caste, there are also subdivisions within a caste. So a Janajati can be of a higher caste or of a lower caste. So remember that it's very intricate. So like that. And then also, so we see that clustering right there, but then we also see a clustering at the lower end where an individual, again the self, finds that they have been affected in the past or currently by caste. And these were generally of lower caste, the Dalits and the Janajatis again. So this is kind of an interesting relationship that we found through our research. And again, we did have a small sample size, but something to consider is that caste discrimination within this population is present and can affect their mental health. So additional trends that I'd like to highlight really quickly that I found interesting and our group found interesting was first caste within the community. So a lot of our interviewees, I think 64% of our interviews indicated that caste doesn't have an effect on them, doesn't really affect their well-being or doesn't really matter to them. However, something interesting was that majority of them indicated that caste is still very prevalent within the community. It's something that a lot of individuals still adhere to, a lot of individuals still think about, especially the elderly. We found that the elderly community still holds on to the system. And this is important because as individuals are resettling to the United States or any other third country, it would be interesting to see, do they still adhere to this system? Do they still hold on to it? Do the elderly members still hold on to it? And what implications does that have? Additionally, we looked at how the role of, or a lot of our interviewees addressed how the role of education and international organizations has played a role in caste discrimination. A lot of interviewees said that there are a lot of factors that has kind of played a role in decreasing caste discrimination, and the front runner of that was education and international organizations like Oxfam and Caritas. I remember one of our interviews that Jenny and I did, a woman was talking about, caste discrimination was very prevalent in Bhutan and when we first moved here. However, with organizations that have come in, caste is nothing now. So that was something that really stuck out to me. And then finally, something that I had no intention of really pursuing, but kind of just came up as we were doing our interviews, was the role of religion. How changes in religion and religious practices are heavily tied to the caste system. We talked to 8 individuals who indicated that they had either changed their religious beliefs, i.e. they actually converted from Hinduism or Buddhism to Christianity, or they had changed religious practices within their own religion. And all of the individuals who had either changed their religious practices or converted were of lower caste. So they were either of Janajati or of Dalit caste. So there was no individual that we interviewed of Brahmin caste who indicated that they had changed any religious practices or beliefs. And this is interesting because a lot of the individuals, they would talk to us and they would indicate that when I was of this religion, whether it's Hinduism or Buddhism, I would suffer from headaches. Or one woman specifically told us she had heart trembles and limb aches. And then once she converted, and as well as her mother no longer had suffering. They were at peace, and her son was no longer an alcoholic. So there was clearly some kind of link between, or there appears to be some kind of link or relationship between religion, caste, and how that may be playing a role in the mental well-being of the refugees. However, further research is needed, especially since we had a small population, and it just kind of emerged as we were conducting our research. So to wrap up my section, as I mentioned, I primarily want to focus for this presentation on the relationship between caste and where one perceives themselves in the caste system and mental health. And we see that there's a negative relationship. So the lower an individual was in the caste system, they were more likely to indicate that they either had suffered issues related to their mental health or were currently suffering issues related to their mental health. So this led me to develop some questions or further become intrigued about how does the caste hierarchy play out once an individual resettles to the United States, especially since in the United States there isn't a clear social system similar to the caste system. An individual can certainly adapt to it or make one up as they are living here, but how does that play out once they're resettled, especially for the elderly population who many individuals indicated to us that they still adhere to this system. And then also, how does access and utilization of the health services differ by caste? There's an interesting article, and it was pretty recent in 2010, where the study revealed that Dalit children, those again of the lowest caste, they experienced caste discriminations in numerous sectors of healthcare. That they included longer waiting time, not adequate service to counseling or mental health facilities, not adequate service to a physician when they needed them. So it'd be interesting to understand how does that play out in terms of how does an individual or a refugee have access to health services or mental health services within the camps as well as once they resettle to the United States. So I'm going to pass it over to Elise, who will explain her story.
So this is just a really quick outline of the 3 things I want to touch on in my results section. First, again, back to the psychosocial context thing. Remember, it's kind of like the landscape of the mental health, how they understand mental health, how they experience it, how they respond to it. So first, we wanted to kind of just gauge their awareness of the mental health that exists in the camp. So we asked them, does it exist? Do you know people? What do they do when they get it? How do you guys deal with this here in the camp? And so these are a couple of examples of the responses. One guy said there's 100% mental tension, which is kind of it's one of the terms they use, probably for something like anxiety or distress or, it was hard to translate exactly what it meant, but it was their kind of word for this mental distress. And another person said there's much depression in the camps. And so only 3 people we talked to didn't know anyone personally with mental illness. I mean, this is them saying, you know, these people weren't, we didn't diagnose them and say there's only 3 people that don't have it, but 3 people said they didn't know anyone with that, or 3 people said they didn't know anyone personally. 2 of those people said there probably are people, even though we don't know them, and 1 person described having symptoms of mental illness themselves. So they are aware that it exists, and they are aware that there is a lot of it. Also, most of the treatments they talked about, when we asked them, like, what do you do when you are mentally ill or when you get tension or depression, and a lot of them were very community and family focused. So they do have some resources available to them, but they're very limited. Some of them said that if these things didn't work, they would go to AMDA and get antidepressants. But one example is, one of the girls we interviewed said that her aunt got a severe bout of depression, and she would go and sit with her every day and kind of talk to her, encourage her, help her think of action steps she could take to kind of work her way out of it. And eventually her aunt got better and was able to kind of get through that bout of depression. And another example is that a lot of the divorced women and widowed women have created support groups where they kind of meet together and discuss their experiences together and kind of act as counselors for one another, which is really interesting. Well, we'll talk a little bit more about that later, but that's kind of where they first go, is to kind of their community and their family. And then also we wanted to know what they thought contributed to it, and there were a lot of things. They're not even all listed here. Tulsi obviously touched on caste, so I'm going to focus on resettlement. So as some of the resettlement anxiety had to do with things that were happening in the camps, so their cases being processed and their interviews for resettlement was a common response when asked kind of what causes them worry and anxiety. But most of them had to do with their expectations of what resettled life was going to be like. And as we kind of looked at these expectations, they 2 kind of apparent categories kind of broke them up in. So they don't all fit perfectly into them, but for the most part, there's kind of like their contextual expectations and then their expectations of what their identity would consist of in the U.S. And again, I'm only going to get to touch on a few of these because we don't have too much time. But so first of all, and I have a couple of quotes, so I want to make sure I get these right, but every participant said, we also did a question like on a scale of 1 to 5, how important is it to live near family, and how important for friends and other Bhutanese, and everybody said it was really important for them to live near family. And most of them said that it was very important for them to live near other Bhutanese. And their explanations for this, one person said that it was really important to live near family because they needed to learn from one another and encourage one another. And then one person said that she had a really strong desire to live with other Bhutanese because then their community would be the same as it is in the camps, but with less gossiping because everyone will be busy working. And so this kind of just illustrates that there's a strong emphasis on continuing to live as a community, not being isolated from their family, not being isolated from other Bhutanese. And in many ways, their expectations with this kind of paralleled their community there in the camp. So when they came to Bhutan, from Bhutan to Nepal, they kind of came as a unit and they experienced this, life as a refugee somewhat as, a unit, and they have shared experiences all around them. And I think in a lot of ways they expect that coming to the U.S., that they'll have these people around them that they can kind of arrive with and figure things out with. And so we find that this is often not the case in the U.S., that some people had family members that were resettled in all different parts of the U.S. Oftentimes they're not resettled as a community here. They don't always know where other Bhutanese in their towns live or how to network with them. So this expectation has a potential to be really disorienting once they arrive here, and it's not as much of a communal, shared kind of journey. The other thing that was really interesting was this expectation that life in the U.S. would be more difficult, but that they would be happier here. And so we asked them, do you think you'll be equally happy, less happy, or more happy? And then we asked, do you think it will be harder, easier, or equally hard? I don't expect you to read this all, but the general trend on this chart is that they think they will be happier, but that it will be more difficult. So this lady said she thinks she will be, this lady here, she'll be excessively happy. And this person said that she thinks it will be harder because she wants to, oh wait, sorry, the one below it. It will be more difficult, but he will be happier. And this one up here I think is the most interesting for me. They think, this is a female, she thinks that it will be harder, but that mentally and physically it will be easier because there's depression here. So there's kind of like this implicit expectation in that response that in the U.S. they won't really face depression the way they do in the camps. And as Tulsi mentioned earlier, the IOM reports have found that the suicide rates are actually higher here, and it seems like mental health outcomes are only getting worse. So it's an interesting expectation. And then I'm going to touch on one from the identity category, although they're all really important, and I could talk all day about the citizenship thing. That was a huge, really interesting theme that came out. They just really, anyway, so we'll get into that. But so they have this really big fear of the job scene here being very difficult, you know, which is understandable. And it was especially the people that were illiterate or didn't speak English were particularly fearful, but also the people who were really well educated in Nepal and who in the camps had positions of prestige and power and kind of respect. So the people that were principals in the school or teachers or community health workers, they were really fearful that they would come here, that their education wouldn't really translate, and that they would be working these low-level jobs where they weren't respected and they weren't making enough money. And the other fear was that they wouldn't be able to keep their jobs because they have this crazy idea that in the U.S. we all work ourselves to death and that we, I don't know where they got that impression, but so yeah, they kind of, I think they've been warned and understand the work ethic here. And one lady, she said that in the U.S. there's a higher time value and that it might be hard for her to do things on time. If she got tired, she would not be able to make excuses and take a rest. So in this sense, their expectation is definitely going to be met, but we'll talk later about how there's kind of another element at work there. So the last result I want to touch on before we discuss briefly is the experience of telling their life story. So there's a lot of literature on the effectiveness of narrative exposure as a form of therapy, and our intentions weren't therapeutic at all, but there was a level of acknowledgement that this might, being able to tell their life stories might be beneficial to them. And so we didn't try to measure that benefit, but we did want to gauge whether it was a good experience or a bad experience, and it was overwhelmingly positive. And this was my favorite quote, so I had to share it. I didn't do this interview. I don't know whether you guys remember this, but 35% relief and peace in my heart after interviewing. That, you know, makes you smile. But overwhelmingly, people said, we are so happy to have been able to tell our stories because no one has ever asked us for our story. Again, you know, they all kind of had experienced the same thing, so no one's really interested in their individual stories there because it's like, yeah, like, so what, that happened to us all, you know? But they do have individual stories, and it was important for them to share those. So I'm just going to discuss a couple things really quick, just some implications, and then we'll have some time for questions. But although we don't have a lot of individual level data here with resettled refugees, where we can kind of look at the way that their expectations and their realities kind of either matched or didn't match, we do have a lot of general knowledge about what life is like in the U.S. and specifically for low-income communities, and specifically for low-income communities who don't speak English as a first language. So we can kind of talk generally about how some of these expectations might be problematic and put them at risk for poor mental health outcomes. So there's a lot of them. We already touched on expectations of communities. So the one I'm going to focus on here is this non-traditional roles. So I think that although they definitely expect that working and providing here is going to be very difficult and it's a big fear of theirs, I don't think that that expectation kind of includes this transition of a very non-traditional provider roles kind of emerging here in the U.S. And what I mean by that is when young people come to the U.S., or in the U.S., young people have a higher marketability in our workforce typically, and especially if the older people don't speak English and the younger people do. And so the young people, like 20s through 30s, tend to become the primary providers once they're here. And if you think about it, those are the people that were either, I mean, they've been in the camps for 20 plus years, so we were either born in the camps or came to the camps as children. They've never really, for the most part, had this burden of I'm the sole provider, and sometimes this means providing also for their young children or younger siblings and parents and or grandparents and or in-laws. And so they kind of have this unexpected shift as primary provider, and usually with very low income jobs. And so if you think about this trend, you can imagine that single mothers are particularly at risk for kind of poor outcomes from this new, non-traditional, kind of probably non-expected role. And this is consistent with the IOM report that said that single mothers who had several children and no support network were more prone to suicide here in the U.S. In this population specifically, not, I don't think, in general. So since we know they have this burden, it's important to at least touch on the potential health or access to mental health care they could have once they're here. And this story is a whole lot happier. There are obviously a lot of barriers, physical and cultural. And I talked to a lot of the free health clinics around the Raleigh-Durham area, and none of them are really able to offer mental health care, at least not extensively. One said that they had some group counseling sessions, but if you think about the need, these refugees that are here need to know that these resources, even the limited resources, exist. They need to know where they are. They need to be able to figure out transportation for getting there. And furthermore, like, these group counseling sessions are almost certainly not conducted in Nepali, and you can imagine that when you're discussing things of that nature, it would be very hard to really get very deep in a language you weren't very familiar with. So it's not really clear how effective those would be. And also the people leading the group counseling sessions probably don't, at least at this point, hopefully they will, but they probably don't understand necessarily where the Bhutanese are coming from, their histories, their stories, what specifically they deal with. And so one potential advantage I'll touch on really quick is that, and this may, or this is, I'm not going to emphasize it too much, but there didn't seem to be a huge taboo about talking about mental health in the camps. I don't know if that's because there's just not as much of a taboo in that culture, or whether it was just because they felt really comfortable with us. But that might be one potential advantage to health-seeking behavior of Americans in general, but that's all here. So where to go from here? I know we've kind of driven this point home in both of our aims, but I just want to mention it again. I think it's important to use this data. It's so rich. We have so much of it with all these life stories to really kind of inform all of the players in this process of resettling them. Also, like I mentioned earlier, we don't have a good set of life story interviews that are conducted with resettled refugees. We tried to start doing that this year, and we ran into a lot of difficulties. One, it's just hard to find a lot of different pockets of them, because there's not, you don't just walk through the camp and have them coming out to you. You really have to find them, and it's hard, and they don't even if you find one community, it's hard to find, they don't necessarily know where other refugees live and things like that. So it's hard to find them, and also they have so much time in the camps. Time's a luxury there, and it's obviously not here, and so these interviews do take time. So we've tried to kind of alter the tools so that it takes less time, but anyways, I know Keenan Institute is still working on doing this, and I think it'll be really valuable. And then lastly, I think this is so cool, is this public, sorry, I totally went in a weird order down this slide, but Keenan Institute is also creating a public archive of all of these life stories. We got consent for this from each person. And this will kind of serve as like a public database that we, the general public can have access to, but also the refugees who are living here can. And I think it's so neat because it's kind of an effort to continue telling their story, and for them, I think it will be encouraging to know that they have access to their story and other stories like theirs, and that other people do too, and that they're not just this kind of invisible, forgotten, and isolated group, but that they really do have rich and interesting stories, and that now they're becoming Americans, and that's going to be part of our story. So I think it's a really neat effort, and I'm really glad that Keenan Institute. So we would like to acknowledge the following people.
So for both Elise and I, we had a tremendous experience in Durham as we were preparing for it, as well as in Nepal, and it wouldn't have been possible without a lot of people, primarily our advisor, Dr. Shanahan, the brilliance of Dr. Shanahan and her guidance throughout this entire process. Our committee members, who I don't think are here, but they reread and read and continue to reread our drafts, and that was very helpful. Our fieldwork team, a lot of them are here, as well as our translators in Nepal.
Lou and Jenny and Kieran and Dominique and Esther, they were all on our team, so
Yeah.
they are responsible for so much of this research.
A lot of it, actually. And then also our translators. None of us could speak Nepali fluently, so we probably would not even have a live interview. So it was very helpful that they were there to guide us and also help us with the daily living in Nepal as well as with our research.
So, of course, DGHI provided us with the training and education and the resources and all the support, so we're really grateful, of course, for DGHI, and as well as Keenan, who gave us a lot of the same resources, support, and training, and then, of course, family and friends, all of you. Thank you for coming.
Thank you.
We can take some questions.
That was a really great presentation and very interesting research, so great job, guys. I have a question for you, Elise, about were any of the realities that they experienced once they resettled better than what they thought they might be?
I'm trying to think through all the different ones. There weren't any that stood out as being like, oh wow, they think this is going to be really bad and it's actually going to be awesome. But I think it was good to see that some of their realities or their expectations were kind of consistent with how it's going to be. And I guess IOM is the one that does the cultural orientation classes before they resettle, and they try to drill into them a lot of these things about work in the U.S. and things like that. They do this one exercise where they're all in a room, and then the person who's leading it drops all of these notebooks in the middle of the room, and there's like not enough for everyone. And they're like, okay, come get a notebook. And so everyone has to like go and dive, and like the old people are like, just trying to get up there. And then they all get their notebooks, and some people don't. And they're like, this is what it's like in the U.S. to get a job. You have to be aggressive. You have to go for it. And some people won't get them if you're not like. And so they do funny exercises like that. So I think it's good.
But they're relevant also. We all sat in different classes, and I don't know, it seems funny to us that they're very relevant stuff. Like Jenny and I experienced the fact that the teacher put a telephone in front of an individual, and it was like an old telephone. That generally we use telephones now, but how do you use this thing? Like, how do you dial a number and call 911? That's something that we're all so familiar with, and it seems funny to us, but it's the reality in the sense that when you're placed in a position where you don't know anything or not aware of the system, you're not aware of it, so it's very difficult. It may seem funny, and it did seem funny to us, but it was.
So I would say none come to mind. I will look back through all the different ones, because I didn't get to touch on all of them, but none stood out. That some of them it was like, okay, good, they have a realistic expectation, but there were none that kind of had that, oh, you're going to be pleasantly surprised, So.
Is there any job training that they do in the camps before coming here? Because if they haven't been working for 20 years, I imagine just getting back into the workforce would be challenging.
There's not any, at least not that we saw, formal training. Some of them do have jobs, but, and I think this might have been, I don't know if this is kind of a rule or an exception, but there was one example we heard of a guy who got a job and then quit, and they were like, why did you quit? And he's like, well, they made me work. And so I think that
I think the cultural orientation classes do provide some information about what would you expect in terms of how to get a job, how to dress professionally, or something along those lines, but not specifically in terms of if you get this job, this is what you are expected to do compared to this. And although in the camps themselves there are teachers, there are health workers, so some people do have experiences. However, if you go to look for another job once you're resettled, that may involve training on the spot.
How did you guys, what was your perception on how UNHCR and all these like organizations were taking care of their mental health in specific?
Well, so I don't think that it was kind of in, well, so TPO is the organization
That provides health.
So AMDA provides health care. TPO is sort of what they see as their mental health care provider.
Mm-hmm.
But when TPO was established, its mandate was more to settle conflicts, like conflict resolution between families on issues of resettlement. So a lot of families, some people want to resettle and some don't.
Mm-hmm.
It's not an option. I mean, they all have to resettle. They're closing down the camps, but there's still a lot of people who think they're not going to resettle, and it's not clear what they'll do. But so I think people see that as kind of the main mental health resource, but they're not really able to provide a lot of resources at all. They have some group counseling, but yeah, I mean, and maybe you can speak more to this. There's not a lot of resources for them. There's a lot of antidepressants everywhere. Like we went through, one of the camps burned, and we went through when we first got there just to kind of see the remains of it, and just littered on the ground are like antidepressant packets and pills. So I think that's kind of, oh, here, you're depressed, here's some, and I don't think it's, it's really hard. They have to provide everything for these people, and we all know that there's so many limitations when you're an aid organization. You can only do so much, but there's not a lot of mental health care.
I was going to touch on the fact that antidepressants are available. As Elise said, first thing that came to my mind was that story of when we were in the camps, we were just walking around and there were antidepressants like literally littered everywhere. You just found them there. And so they're available, but everyone has a different need in terms of what factors are in play for them individually. I think while there are services available, they're not catered to the individual. So an individual doesn't have the time, or maybe the services, they don't have the time to sit down and have a session where you have an individual session and then you come back and have another one and see the progression or if there are any changes. So it's not catered to the individual, from my understanding. So I think that's something that does need to be addressed.
I had a question for you, Tulsi, about how you determined how their caste affected their health. What were I know you said you used some sort of indicator terms like tension, but what were the other things that you looked at? Because I think that my work will be fairly similar, so I'm just interested in hearing what were those things that you helped to describe that?
So I was talking to Elise about this, but when we were thinking about developing our survey, we already had a kind of a format of the life story interview, and we embedded our questions. Something that was very useful for me, and Elise touched on this, said this as well, was the scale. So our research was all qualitative. However, to kind of have an idea of numbers and to put something together, I asked the question of how does your perception of caste affect your mental health, or how do you think it does, based on the scale of 1 to 5. And that really helped me because we could ask that question and they specifically would answer that question or answer something similar to that question. Now, if we didn't get around to asking that question or there was no response to that question, many individuals would either bring up a story that would address something that was related to their mental health. And oftentimes there was these key phrases that we learned as we were doing these interviews that were primarily anxiety, tension, or stories. So another way that I learned about how caste was influencing mental health were stories. So there was this trend, and I didn't touch on it, but there were these similar stories or trends that were told about how caste discrimination at the water pumps, intercaste marriage, caste discrimination at temples or religious services. These very familiar stories that just kept repeating themselves over and over. And that kind of was an indicator for me of there was some kind of relationship here. So with qualitative research, what I was told by Dr. Shanahan and also other individuals was that as you're interviewing, either you would get to see trends that you would expect or not expect, and those trends would help you identify key phrases. So hopefully that helps.